Okay, well, my name is Alison Mitchell. As Jonathan said, I'm a palliative medicine consultant over in the Beatson, and I'm lucky enough, I think, to work with the chronic pain consultants who come over on a Wednesday at the Beatson. We run a joint interventional clinic. So what my aim is to kind of explain the integrated approach that we have and the things that we can offer patients, and hopefully make it relevant to primary care for you. So what I thought I would do would be to give you a bit of the evidence for intrathecal drug delivery, a bit of the science behind it, an overview of what was the Glasgow service, but as of next week will be the regional service. A little bit about the technical bit, and I've stolen that information and slides from my chronic pain colleagues because they really do the technical bit. I'm going to tell you the audit results because that's the important thing, does it work or not? And then give you a bit of information about governance, training and patient information. So, why do we need an integrated approach? Well, when I first started as a consultant in palliative medicine, I was part of a sarcoma national group, and there was a lovely senior orthopaedic surgeon colleague from Aberdeen who looked at me and said, palliative medicine, bottle of Glenmorangie down to the river. So, but I think we can maybe do a wee bit better than that. So, you know, as a specialty, we're quite a young specialty, but I think whisky is one approach, but there's maybe some other things we can do as well. So our big door-stopping book is the Oxford Textbook of Palliative Medicine, and the chapter looking at interventions for cancer pain control sort of underlines the fact that a percentage of patients, even if you do all the right things with the WHO ladder, still have inadequate pain control, and that interventional pain therapies can work, but they're often underutilised or withheld to the very end of life. And equally, in the chronic pain literature, the British Pain Society put out this little book about, it was 2008, so that's about 6 years ago now, again saying the majority of patients with cancer pain could have it controlled following WHO guidelines, but there's a percentage that will require more intensive measures. And their summary was that intrathecal drug delivery appears to be underused in cancer pain. So that's the WHO Analgesic Ladder, obviously, bread and butter. It doesn't achieve pain for all. There's a fourth or even a fifth step, depending on what you think about. And I firmly believe that you don't necessarily have to go 1, 2, 3 and a long time at 3, swapping things around, and then look at interventions. Really, if the pain's severe, you would have interventions in your mind from the word go. Interventions should be considered early, and my brain works in a fairly simple way usually. And basically, if you've got a big bit of tumour invading a big nerve, I'm never that sure that all the sort of adjuvants and all the oral analgesic routes are going to work, and maybe we should be thinking about things that we might be able to do to block that nerve. So what's on the fourth step? So interventional anaesthetic blocks, which is what all this is about. Surgical procedures, radiotherapy is a really good pain control, particularly for bony type pain. Interventional radiological procedures, and then sometimes we obviously use some of our unlicensed drugs like ketamine or even lignocaine. What types of cancer pain do we look at? Well, the interventional service, a lot of what I'm going to talk about is actually to do with our intrathecal service. However, the interventional service, we consider a range of blocks depending on the type of pain. So this CT scan shows a big mass in the psoas muscle, which was causing this gentleman significant pain. And the scan on the other side, so there's two different scans, scan on the other side shows a rectal mass in between the rectum and the bladder, which was causing a great deal of sacral pressure and discomfort to the woman who was our first intrathecal drug delivery patient. So for the intrathecal drug delivery, I suppose the patients that we're looking at are patients that have got dermatomal distribution, probably T12 and below, but we have considered patients with pain higher than that. So for intrathecal drug delivery specifically, what's the science behind it? Well, The catheters that we put in allow the drugs to be delivered continuously into the CSF, and the mixture that we use is an opioid and local anaesthetic mixture, so it goes directly to the dorsal horn. Intrathecal opioids inhibit pain transmission. The effective dose is about a 300th of the oral dose, and that's really useful for patients where they are not tolerating the sedative side effects of opioid analgesia, which ends up being quite a big proportion of the patients we see. They're effective when we give them intrathecally, and they really have very few side effects. One of the things we realised when we first started doing this, we first started the Greater Glasgow service in 2008, so it's been running for about 6 years, and we've now done about 30 patients, or put intrathecal devices into about 30 patients. And one of the things that became apparent for some patients, the sedative side effects were protective. And one of the waking people up after an intrathecal pump's gone in and actually they don't have all the drowsy side effects. We now warn them about that because sometimes the reality of what's happening can be hard for people. The intrathecal local anaesthetic is key in my view. We don't have an oral option for local anaesthesia, so it's completely new for the patients. They can benefit from local anaesthetic. The local anaesthetic is delivered directly again to the site of action, the dorsal horn. There's a sodium channel blockade. We have a kind of really careful titration schedule, so our aim is to have patients with sensory blockade but minimal motor blockade. So the idea is we block the sensory nerves but they're still walking around. That's what we're aiming for. And it's reversible, so if we give them a little bit too much local anaesthetic and we get a bit of a motor blockade, we can trim it back and aim for a sensory blockade. So with one exception, all the patients that we have wanted to block the sensory nerves and not the motor nerves, we've managed to do that. Okay, so this is a kind of summary slide of how the service works. So you're taking a patient who's on all these medicines, which you'll be well used to, the Severodol, MST, hydromorphone, and in 2 stages, we initially, we implant the catheter to get to have a trial phase where we deliver intrathecal morphine and local anaesthetic via that purple pump in the end slide there. That's it's a CAD legacy PCA, and we have a week or 2 weeks trial to get the dose right, so we get pain control, no motor block, and we trim back all the oral analgesics. And then if all that's successful, they go to the next stage, which is a fully implanted pump, which is that Codman round pump down there, and they go back to theatre and that's implanted, and that's what you should get at the end of a fortnight, or maybe a little bit longer when the wound's healed. So they end up with a pump under the skin in either the right or left flank, which continually delivers the mixture, and needs refilled every fortnight. So the cancer pain service was established in 2007. We set it up with the British Pain Society and Association of Palliative Medicine guidelines that I showed a little bit earlier. We set it up with quite robust clinical governance, which we try and maintain. It's compliant with the relevant health department letters. It is a service that has always been aimed at the fitter cancer pain population, so we haven't aimed it at end of life. We've aimed it at the fitter patients, so patients that are able to get up and out and maybe do a wee bit more, particularly if their pain's well controlled. And we went for a hub and spoke service design, so the Beatson and my chronic pain consultant colleagues and the palliative care team in the Beatson are very much the hub, but we try and make sure that we can support the patients wherever they are in the community. I'll talk a wee bit more about that. This slide, I'm sorry, is a little bit busy, but basically it's a summary of the flow chart of how patients are referred. And this is how we're aiming to do it from really next week, I suppose, when the regional service starts. If there is a patient who has cancer pain and they're known to a palliative care service in either Greater Glasgow and Clyde or the adjacent health boards, and they've had a trial of all the appropriate analgesics, they're known to the local palliative care team, but either the medication is not adequate to relieve pain or they only get pain relief with intolerable side effects, then they can be referred to our integrated palliative medicine chronic pain clinic and assessed by chronic pain, palliative medicine, clinical psychology and physio to look at suitability for intervention. And once they've been assessed, there's effectively 3 outcomes. There might be an indication for intervention that's not an intrathecal drug delivery device, for example, a celiac plexus block or a neurolytic block, or perhaps a cordotomy, which Gordon's going to want to talk about, and in which case that procedure is planned and they come into the Beatson and have that done. An intervention might not be indicated at all, in which case they go back to the referring palliative medicine team. Or in the middle block, then we think they might be suitable for an intrathecal drug delivery device. If that's the case, it was usually a fairly extensive consultation with the patient, family, oncology team, because they're usually still being actively treated, the primary care team, ourselves and the chronic pain consultants. So if that is the case and that's what's needed, then we make sure everybody thinks it's a reasonable idea. The primary care team view is very important. I remember having a discussion with a GP in Paisley in December about a lady that had been referred. The GP really felt very strongly that the pattern of pain that was being reported hadn't changed and was very dependent on what was going on socially. The sort of information that maybe would be only primary care would really have that clear information. So it's incredibly useful and was one of the bases on which we didn't in fact go ahead. But if everybody does think it's a reasonable thing to go ahead, we plan the dates for the 2 stages of the procedure. They come into the Beatson, and the first stage I've described, and that's the trial stage with the external catheter. And after that, a week or 10 days, there's 3 possible outcomes to that. If it's successful, then we go on to put the pump in. If it's not successful, if it's successful but for some reason they're not appropriate to get an implanted pump in, then we see if we can arrange to continue with the percutaneous pump. Or if for whatever reason it's unsuccessful trial, then we take the whole thing out and refer them back to their specialist palliative care team. That doesn't happen very often, but it has happened on a couple of occasions. It's obviously very disappointing for everybody, not least the patient. But if we look at the successful approaches, then if they get the Codman pump in, they don't have to stay in the Beatson for very long, just a couple of days afterwards, and then they either go straight back home, or if they've come from a hospice, they'll often go back to the hospice before getting home. And then we have weekly phone calls with the patient, weekly reviews. We've got, I hope, quite a robust system where we speak to the patient every week, find out how they are, liaise with the local palliative care team. If their pain's increasing, we may need to change the refill mixture. And we see them every fortnight in the clinic. And if they can't come to the clinic, we will go to them. So it's quite a lot of, I hope, clear communication. They get a big discharge pack to go home with, and we go over things quite carefully with them and their next of kin. If they need to go home, if they need to be discharged with the external pump, there's a bit of training involved in that, in terms of the pump not being familiar to everybody that might be dealing with it. So if they were going to go back into the community with a CAD pump, which we've had a couple of times, we would contact the primary care team and then arrange to go and see them and arrange to get some training so everybody was comfortable. It's worth stressing that we will always take responsibility for it. We don't expect the primary care team to take responsibility for the infusion. We'll always do it, we'll always change the cassettes, but what we're looking for is a monitoring role. And the couple of times we've needed to do that, it's been fine, hasn't been a problem. So that's what happens. That's how the referral process works. So it's very much a joint consultation and a kind of maybe wider virtual MDT decision on how we go about doing this. When we do the assessment, we're really looking at not just the diagnosis, but the prognosis, what oncological treatments they're having. We do a pain assessment in the form of a British pain inventory. We look at comorbidities. The social history is really important. Psychological assessment, the sort of distress element of the pain is really important, and probably the biggest single reason why we sometimes turn people down is if we think psychologically they might struggle to cope with it with the implanted pump. They need to be able to understand the process, and we need to get a feeling that they'll comply with a follow-up, returning for refills. That's really important, and that's where some of the primary care feedback can be really, really useful. We look at risk factors, and from the chronic pain consultant's point of view, the body habitus for surgical procedures. Although we've had some fairly complex abdomens, and I think most times we've found ways around it. And we have involved a surgeon when there was a young woman with cervical cancer and multiple previous procedures. We got a surgeon to help us out. So. And then we do a bit of governance assessing, and we go over things in detail with the patients. We've got both an information leaflet and a patient DVD from 2 patients who got on very well with it. So we've got all of that. We have a sort of checklist that we look at just to make sure that we've done all the right things before we say we're going ahead, and then the patient comes in. So. Then when they come in, that's when my chronic pain colleagues get involved. It is a 2-stage procedure. We've talked about this and we've talked about that. And they're looking really to thread the catheter to the most relevant dermatome. That's what's important. So this is just a picture of the first stage when the wee incision's been made in the back, and they're tunnelling. I think that's the guide wire, but they're tunnelling the guide wire, and then they'll put the catheter over it. To get it round to the flank. And then it comes out at the front of the abdomen and is connected onto the CAD pump. And usually we've got a nice dressing applied and attached to the CAD external pump. And then we have our week or 2 weeks of monitoring, and the Archimedes pump is put in. The Archimedes pump we use, there are more complicated pumps. There's Medtronic pumps, there's variable rate pumps. The Archimedes pump is simple. It's a fixed rate, so we can't change the flow rate and we can't bolus with the pump. However, it's probably the cheapest of the pumps in the market, and that's quite important. It's a fixed refill interval, which is good. We know exactly what we're doing with it. There are occasional patients that you think it'd be really nice to have a variable rate pump, but most of the time we've managed with a fixed rate flow pump. So we haven't, every now and again we think we might change it, but we haven't done that as yet. I think costs might be a problem if we try to do that. That's just a close-up of the pump. Before the pump goes in, that's a 60 ml pump we use. So it's like a small donut, it's about that size. And it goes into the patient subcutaneously, because obviously we need to refill it through the skin, so it's important we can reach it. And it's filled up by the chronic pain consultants before they pop it in. That's just a picture of the procedure. So going into the pocket that they've made. And that, after the wound's healed, is what it looks like. The sort of nub you can see in the middle, that's where we refill it every fortnight. So it's not a difficult procedure to do at all, the refill procedure. So I guess the important thing really is, well, does it work? How have we got on doing this? And this data is correct up until last August. So until last August, we had 28 patients through the service. The average age was 56. We did 10 men and 18 women. And their diagnoses, you can see they're kind of, a lot of them are the lower body malignancies. So 9 patients with colorectal or anal cancer, 8 with gynecological cancers, 5 patients with lung cancer, and then a mixture of a few others. Okay, so of those 28 patients, 27 had the trial line and then with the CAD pump and then the Codman, and 1 went straight to a Codman because that lady was already bedbound and lost the use of her legs. So titrating the dose up to maintain mobility wasn't an issue for her, and there was an infection control issue as well, so it seemed safer to go straight to the Codman. Of the 27 that had the trial line, 18 of them went forward to the second stage of the Codman pump. 5 folk, the trial wasn't successful for a variety of reasons, and 4 stayed in the external CAD pump. There's a variety of complications. Motor block in the titration phase is quite common, but as I said earlier, it's something we can get over. We just alter the dose of local anaesthetic. Post-Europuncture headache is common as well. About 25% of patients have that. 3 of them have needed epidural blood patches. And interestingly, we titrate the oral analgesia down very quickly as we commence the intrathecal infusion. And it's not uncommon that we see opioid withdrawal the day afterwards. So patients become quite agitated, and it settles very quickly if you give them a low dose of their opioid. So as we've got more experience, we've got used to the side effects and are reasonably clear what we're doing to manage them. This, I guess, is the interesting thing. This is the why we do it, and the fact that we do bring people's pain scores down. So if you look up at it's a British Pain Inventory score. So if you look at pre-intrathecal drug delivery, the worst pain in the last 24 hours, the average was 9.2, and then immediately post intrathecal, so they still will have wound pain, but we're not scoring that, we're scoring their cancer pain. It's come down to 5.8. After 7 days, their worst pain is 4.6, and 8 to 12 weeks it stayed low. And if you look at their best and average pain, they've done very similar things. So they come down significantly and tend to stay down. And that's it in a graph form. So it works for patients. And these patients are the most difficult cancer pain patients that we look after in palliative medicine. In the ones my colleagues across GGC are scratching their heads thinking, we're not sure what to do here, and their pain scores come down. So we've had some good results. Again, if you look at their oral opioid consumption, before the intrathecal drug delivery catheter goes in, the average morphine consumption in 24 hours is about 1,200 milligrams of morphine. So some of them will be on fentanyl or oxycodone, but if you convert it all to an equivalent dose of morphine, it's about 1,200 milligrams of oral morphine. And 7 days post-insertion, none of the patients were on regular oral opioids, and their average breakthrough dose, breakthrough dose 7 days, because they will have oral breakthrough, is 29 milligrams of morphine. So their morphine dose again has come right down. So there's a lot more clarity. A lot of the opioid side effects have gone by then. We also bring down the non-opioid drugs, so pregabalin, clonazepam, all the other things patients end up on, and taking that whole raft of drugs off makes a huge difference to people. When people come to end of life, the pumps, the average length that a pump's in, our average length is about 7 months. It went up quite significantly on the death of a patient in November who'd had it in for the better part of 2 years. Until then it was about 4.5 months, but he's pulled the average up a lot because he did very, very well with it. But when we come to end of life and pain has escalated, what we have found really helpful is to escalate the local anaesthetic dose, particularly if pain becomes an overwhelming problem and the pain has escaped the control of the local anaesthetic dose we've used initially. And what we found with folk in this position is that when you start saying, well, we want to put your local anaesthetic up, but it may affect your motor function, you have to have that discussion several times, and then patients will maybe let you try it, and they get relief from their difficult pain, but at the cost of their motor function. And there comes a point where that's worth it for them. So dose escalation at end of life is something we're now quite familiar with doing, and we discuss it with patients, and when they're accepting of it, that's what we do. Of the 19 patients that had died at this stage, over half of them had had end of life dose escalation. Loss of mobility is an issue, catheterisation an issue. We talk about it in advance, and it does maybe take a few consultations, but they all agreed to it eventually, not necessarily the first time we discussed it. Skin care is really important. Obviously, when people are having big doses intrathecally, they begin to get numb over their pressure areas. So we have to be really proactive about skin care, and we now are very proactive about it. The length of time with an intrathecal drug delivery in situ, that's our 90, but it doesn't include our chap who was, I think, about 600 days. But there's been a variety to begin with. We had patients that maybe didn't have very long, but I think our patient selection has changed over time, and now we've got patients that are lasting longer with it in situ. The gentleman who had it in for nearly 2 years, but I think was a surprise to all of us, but he did very well with it. And the other important point from a cancer centre palliative medicine consultant and from my oncology colleagues' point of view, the fact that they can give active anti-cancer treatment is very important, not just to the oncologist, but actually to the patients as well. They don't want a pain treatment that's going to interfere with their ability to get anti-cancer treatment. So of the 18 patients that had died up until last August with these in place, over half of them had had chemotherapy and or radiotherapy with their intrathecal drug delivery system. 8 out of the 18 had had palliative radiotherapy to new disease, and 5 out of 18 had had palliative chemotherapy. So there was an overlap, some had had both. And MRI compatibility with the machine we have in the Beatson is not a problem, so we can arrange that if we need to. This is the other thing I think is really important, in that these are patients that you would, that really having them at home because of the level of their pain would have been very, very difficult, I think, without an intrathecal drug delivery system in place. And yet we have a significant proportion, I think that must be about 40%, 7 out of 18 dying at home with significant support, but they did manage to die at home. 3 with external pumps and 4 with internal pumps. Now, 3 of them have died with us in the Beatson and 8 in specialist palliative care units. So I think having this procedure or this intervention in place has enabled people to maybe choose their place of death with having a bit more freedom in that. So that's the intrathecal service, and the intrathecal service is just a bit of the interventional service. That's worth emphasising again, that when we're assessing patients, we are considering a range of interventions. Intrathecal is our more complex one, but we do look at other interventions as well. I think we've done about 18 celiac plexus blocks, often for pancreatic cancers, and a variety of other blocks. So there's other blocks that we'll consider if appropriate. So the regional service is really the service that we've run in Greater Glasgow that's underpinned our regional service bid, and the audit results that you've just seen shows that it does make a difference to patients. The governance is really complex, and the bigger the service is, the more work that is to keep the governance tight. The legislation, we need to abide by the Health Department letters. Education and training is key. And what we try to do is train everybody for their specific role rather than trying to do the same training for everybody, which would be impossible. And patient information is key. Patients have to be confident that in the service. So the governance, patient safety is really, really important, and that's the key thing for us. The Health Department letters give us good guidance for the safe handling of the non-cytotoxic injections, and it focuses on good practice, education and training, personnel prescribing, and then all the preparation, labelling, storing, transport and admin of drugs. So we try very hard to be as compliant. Well, we are very compliant, I think. Education and training is fundamental, and we do have formal training and assessment of all practitioners. What underpins it is we've got some Learn Pro e-modules which provide our kind of basic education for the intrathecal service. And then the personnel, we have a non-cytotoxic intrathecal register, which everybody that has got an active role in looking after these patients must be on at the level that's appropriate for them, and competency has to be assessed annually. But as I said, it's not a blanket approach, and it's really about what individuals need to do. So there is a competency document for medical staff, nursing staff and pharmacy staff that really divides the different 8 roles. I cut and pasted if it's come out, right? This is the medical level 3 that would apply to primary care. So if we had somebody, the patients we've had in the community, we would ask our primary care colleagues to be able to supervise the use of an external pump in a clinical setting in conjunction with the paperwork, and to troubleshoot for us in the community. So the training we'd be asking them to have would be the CAD, the pump training, and we would come to the practice and deliver that. We would give them access to the troubleshooting information. Again, we've got that information in a document. We would go out and deliver kind of patient-specific training for the partners if they were keen on that, and every practice so far has been keen to access that. They need to have a familiarity with the intrathecal policy and easy access to the physicians that run the service, and all of that can be done. And so although it is not, doesn't take a huge amount to actually achieve that, it is very much an overseeing role. So we just need to get somebody to come to get the training, come to any medical staff training, and just agree that they would provide supervision. Because very few primary care staff will ever see this, and there isn't an expectation of a role other than a monitoring one. And all the refills will be done by either a palliative medicine physician or a chronic pain physician or a nurse consultant. That would be what would happen. So although we've written it all down and it can look a bit daunting, it's not been hard to put into practice. The Learn Pro e-modules are kind of the key to the education, and they're accessible now throughout the West of Scotland regions. And that's just an example of one of the pages. That section's particularly about refills and end-of-life care for a patient that's dying. While we may make some changes to the intrathecal drug delivery system, it's really important that they get what you would normally do with syringe drivers and things as appropriate, so they can end up having, for example, antiemetics or sedation or whatever in a subcutaneous pump while the intrathecal drug delivery device delivers their analgesia. And also if they develop pain in a different area, if their intrathecal drug delivery device is for pain in the lower half of the body and they develop shoulder pain or pain from a met in their, in their humerus or something like that, you're going to need to treat that differently because the intrathecal is not going to work for that. And there's another end-of-life prescribing with intrathecal prescription systems in place, so that's just more information about that. And there is a little quiz that we use to show that folk have learned and understand all the issues. And people have to pass this quiz annually to stay on our register. So that's, again, not proved too tricky. Patient information is a big part of the joint assessment consultation, which usually takes anything from about 40 minutes to an hour. We've got a leaflet, we've got a DVD. The only thing I would say about the DVD is we picked 2 patients who'd done really well and really wanted to do it for us, and it's possibly a wee bit over positive. When you're actually trying to then say to patients, well, there might be these possible downsides and possible side effects, and then they get this glowing recommendation from the DVD. So I think we maybe need to add some caveats to the DVD, but I'm grateful to the folk that did it for us. So I had a dyslexic moment obviously when I was writing this slide. So interventional techniques do have their place in cancer pain management, and intrathecal drug delivery is, I think, a good example. We do have a really good, safe system for delivering these in the west of Scotland, and we're keen to see patients that might benefit because we feel we've got a good service in place for them. Our local palliative medicine team is definitely the first step, because what we want to do is know that all the belt and braces things have been tried. That's the first step, and then if they think it's appropriate, we are always delighted to see people in the clinic. Thank you very much.